Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Welcome. I'd like to welcome you to our 10th Global Pharmacy Technician Symposium. My name is Susan James. I'm the chair of the Pharmacy Technician Advisory Committee, and I'm delighted to welcome you to this year's symposium. And I know that over the next 2 half days, you're going to hear about and have the opportunity to engage in some really exciting discussions about the efforts that are underway in a variety of different countries, all associated with the work of pharmacy technicians and support workers, their contribution to the pharmaceutical practice, and the continued recovery of healthcare worldwide. Before we begin our program, I'd like to take this opportunity to first congratulate all of our pharmacy technician colleagues, those who are with us, those who are not, as we celebrate together the contributions of this profession on World Pharmacy Technician Day. Congratulations. You are such important partners in the delivery of pharmacy services worldwide and a truly valued member of the healthcare team. You've proudly and tirelessly demonstrated your value and your resilience alongside your team members, helping people all over the world survive the worst of the pandemic. And let's hope that it has been the worst and that we truly are on the tail end of this. As a result of these efforts, people everywhere know firsthand the integral role that you and your pharmacy partners play in meeting the needs of all people around the world. Thank you so much. Now, I'm delighted to tell you a little bit more about our program. As I say, the 10th Global Pharmacy Technician and Support Workforce, and to let you know that it is being hosted by the FIP Pharmacy Technician Advisory Committee. I'd also like to welcome, you'll see coming onto the screen, many of our speakers for today. Thank you very much to all of them. Those of you who are joining us from the wee hours of the morning or the night, whatever that looks like, and for your contributions in our sessions today. I know that you have some very interesting, important information to share with everybody, and I thank you so much for taking the time to do that with us. Before we go too much further, I would like to first introduce and have a few words from our FIP leadership. Although Catherine Duggan, the CEO of FIP, is unable to be with us in person today, she has prepared a few words to get us started. So I would like to ask Ryan if he could play that recording for us and ask you to please listen as Catherine provides us with a warm welcome.
Good morning, good afternoon, good evening, everyone. Welcome. I'm Dr. Catherine Duggan, the Chief Executive Officer of FIP. Welcome today to the 2022 Global Pharmacy Technicians Symposium entitled Pharmacy Workforce, United in the Recovery of Healthcare. You'll see behind me that I have the slide that celebrated World Pharmacy Week and World Pharmacist Day, which centered around the time we had our Seville conference. Complementing that work is your work today. Congratulations on World Pharmacy Technicians Day 2022. So a little bit of background for everyone. The Pharmacy Technicians and Support Workforce was established in 2011 as a focused strategic platform at FIP in alignment with our strategic plan of that time. The FIP-led Pharmacy Technicians Symposium has been held annually since FIP's centenary in Amsterdam in 2012. This year, we've celebrated our 110th day and a decade of that symposium. Subsequent pharmacy technician symposia have been organised under different themes, ranging from developing a strong pharmacy technician workforce to collaboration with healthcare professionals and the evolution of the pharmacy support workforce to become crucial partners in healthcare. We know you are crucial partners with us, and we stand shoulder to shoulder with our technician workforce. During the 2016 Global Conference on Pharmacy and Pharmaceutical Sciences Education, held in Nanjing, the pharmaceutical workforce was defined to include the whole of pharmacy and pharmacy-related workforce, including registered pharmacist practitioners, pharmaceutical scientists, pharmacy technicians, and other pharmacy support workers. As a crucial defined member of the pharmaceutical workforce, the pharmacy support workforce and technicians are recognised within each of the FIP development goals. So, to the symposium today and tomorrow. We're all aware that COVID-19 has disrupted the lives of individuals, our families, our communities, our countries, and our globe, and has put our healthcare systems under tremendous strain over the past 2.5 years, some 31 months, colleagues. The entire pharmaceutical workforce has responded amazingly. We have been an integral part of the healthcare response to meet public's needs. While there has been great opportunity for pharmacy to contribute significantly through the pandemic, the continued strain has also taken its toll, requiring a continued and united effort of all health professionals, including the pharmacy technician support workforce, all of us to help in recovery of the system. Since 2020, the Pharmacy Technicians Symposium has been hosted and delivered as a digital event to promote widespread access to this learning forum. So, FIP today, again, is really delighted to host October 18th and October the 19th, the 2022 Pharmacy Technicians Symposium. The digital event will showcase global roles and practice models among the pharmacy technician workforce globally, building on this theme of resilience and contribution by working with other members of the pharmaceutical workforce towards recovery of our healthcare systems. We have a long road to tread. We now need more than ever to be united to face the challenges we're dealing with and to be prepared for the future ones. We will be looking to make sure that pharmacy technicians feature in all our work about pandemic preparedness, humanitarian support, sustainability, as well as equity and access to medicines. Shoulder to shoulder, colleagues, we will achieve this goal. I'll join you again tomorrow for your closing remarks. And in the meantime, I wish you a fruitful symposium today and tomorrow. Much interaction, much joy, and much collaboration. We know you do this brilliantly, pharmacy technician colleagues, and I'm really delighted that you are taking part today. Happy Pharmacy Technicians Day and happy symposium. Thanks a million for having me. Bye for now.
And I thank Catherine for those wonderful words to get us started today. I'd like to just reinforce a few of the comments that she has made. First of all, FIP has absolutely been supporting the work of the pharmacy technicians and support workforce for a very long time, as she said, since 2012. And the efforts only continue to grow over time. More and more integration within one FIP. As Catherine noted, since the 2016 Global Conference, the definition of the pharmaceutical workforce was clearly articulated with the inclusion of pharmacy technicians and support workers. And as a result of that, it has spearheaded the ability for numerous initiatives to continue to move forward in a way that we have been able to promote much greater understanding. We have a number of activities that are going on that recognize the different education and practice models that our pharmacy technicians and support workers are engaged in, and how the different models work within different teams, different countries, different jurisdictions. One of the goals that we have in all of our work is, as she talked about, understanding that we work shoulder to shoulder. This is about a pharmacy team, pharmacy services that are provided as a team collaboratively. Without that, we will not be able to meet the needs of the public. The Pharmacy Symposium provides just one forum for sharing, and the strategic pharmacy technician strategic platform and the advisory committee, which Catherine noted, allow for a number of other opportunities and initiatives, all under the one FIP activities and opportunities for us to be connected and contributing to all of the development goals at FIP. The advisory committee serves as essentially the primary coordinating group for these activities, and we welcome new FIP members to join the team at any time. So if, as you listen to the symposium, hear the speakers, the conversation, you think that you would like to contribute, to join in any way, then do know that you can just provide us with an email, let us know of your interest, and we will follow up with you. We would like to grow the team. There's much to do, and lots of people helping would be very useful. one of the ways that we work as a team is through various work streams. We have a governance and strategy working group, an engagement and advocacy group, events and symposium, as you're seeing today, and an evidence and resources group. Tomorrow, one of the sessions is going to focus on a couple of the key projects of the committee, the things that we are involved in right now. And so through that session, you'll have a much better idea of the kind of work that we're doing, and also not only how you can contribute, but how you will benefit from the output of our effort. Many of the individuals who are involved with the symposium are members of our Pharmacy Technician Advisory Committee. And so, as I say, watch and consider whether this might be something you'd like to contribute to as well. At this time, though, I would like to turn us over to the program for today. I'm going to introduce our first moderator for this first session, Ryan Burke. Ryan is also the lead of our events and symposium working group, and a huge thank you to Ryan for all of the work he does, not just for the symposium, but in the coordination of a number of other sessions that we have throughout the year as well. I'd also like to just provide, again, a big thank you to everyone at FIP who helps to support the activities of not only the symposium, but all of our work through the strategic platform and particularly the advisory committee, particularly from Marwin Arkell, who is the lead FIP staff support for the Pharmacy Technician Advisory Committee and all of our activities. He provides not only great leadership, but he keeps us on track all the time. He ensures that we're connected with all of the activity at FIP, and is a wonderful resource for those of you who want to join. He's always looking to connect and network individuals. So at this time, without holding things up too much longer, I know that people are here today to hear about our session, hear from the speakers. And so I would like us to get started with that. And with that, I'm going to hand things over to Ryan, and he will get you started with our first session. Thank you so much for joining us, and look forward to seeing you all again tomorrow. We will have some closing remarks. So until then, as Catherine said, enjoy, have great discussions, and we'll see you soon. Ryan, over to you.
Susan, thank you very much. And hello, everyone. Welcome to the first session of the day. I would like to just quickly add my happy Pharmacy Technician Day to all of the pharmacy technicians across the globe. Some of you I know are joining us for the session, and we really appreciate all of the contributions that you make every day, but especially today on a day that recognizes all of your hard work. So thank you for being here. Our first session today is focused on the resiliency of the pharmacy support workforce during COVID-19. As Susan mentioned, I will be your moderator for this particular session. I serve as the Director of Professional Affairs at the Pharmacy Technician Certification Board in the United States. PTCB is the largest credentialing body for pharmacy technicians in the US. And we have more than 283,000 pharmacy technicians in the United States who are certified through the organization. Before we jump into today's program, I wanted to share with you just a few announcements related to the session. The first is that this webinar is being recorded and live streamed via YouTube. The recording will be available later on FIP's website at events.fip.org. I hope that you will have some questions for our speakers throughout the session, and you can ask those questions using the Q&A box that is on your screen. If you have any feedback about today's webinar, please send that to webinars@fip.org. And if you are not already a member of FIP, I strongly urge you to consider joining. And you can learn more about FIP membership on the website, fip.org. I'm very excited about our two topics and speakers today. Once we go through the learning objectives, we will start with a presentation from Shane DeSell in the US, who's going to talk about resiliency among pharmacy technicians. And then we'll turn it over to Alison Hemsworth from the UK, who will talk about the UK perspective on the roles played by technicians during the pandemic. At the end of the session, we should have plenty of time for questions from the audience. And so as you listen to the presentations, please be thinking about what more you would like to learn from our two expert speakers today. So during today's session, we hope you will become to understand the factors that have been linked with resiliency of the pharmacy support workforce, understand how pharmacy technicians contributed to pandemic recovery efforts, and describe lessons learned and what regulatory changes would further enable the support workforce to aid in a future public health crisis. So I'm very pleased to introduce our first speaker, Dr. Shane DeSalle from the United States. Shane is the Associate Dean for Research and Professional Affairs and Professor of Social and Behavioral Pharmacy at Touro University, California College of Pharmacy. He received his BS in Pharmacy from the University of Louisiana at Monroe in 1990 and his PhD from the university in 1995. He has served on faculty at Long Island University, Brooklyn as Director of Assessment at Duquesne University, Associate Dean and Chair at University of Oklahoma, and Dean at California North State University. He is the founding editor-in-chief of Research in Social and Administrative Pharmacy and Exploratory Research in Clinical and Social Pharmacy. He is the co-editor of Pharmacy Management, Essentials for All Settings, 5th edition, one of the most widely used texts in the world, as well as newer texts on teaching pharmacy practice skills and contemporary pharmacy practice research methods. Shane has also received a number of awards in the US and around the world, and he also has more than 120 full-text original research articles published in peer-reviewed journals. And before I turn it over to Shane, I would also like to acknowledge the two co-authors and Shane's research assistants on this project, who are both students at Touro University, California College of Pharmacy, Valerie Wassam and Ashley Woodyard. We're very grateful for their contributions to this important work as well. So Shane, I will turn it over to you. Thanks for being here bright and early this morning.
Thank you, Ryan. It's a pleasure being here. For me this morning, I saw a number of participants already chime in. Good afternoon and good evening. For me, it's 4:15 in the morning, which may explain why that no matter how many lights I turned on this morning, it's still a little dark for me. So I hope you'll bear with me on that. But you'll see mostly, I'm sure, the slides in any effect. And as Ryan suggested, I'd like my two students, as diligent as they are, on experiential rotations right now, and have a hospital shift that starts at 5 a.m. a few minutes from now. So they're not able to join with me this morning, but they were very instrumental in the research and in the project. So without any further ado, let me present to you a number of things that we've got ongoing that I think you might be quite interested in, Ryan. So we completed a project last year that has spawned 3 publications. I'm going to share those with you this morning, and they're all related, but each have their own separate goals. We are going to each one of these papers separately deals with the issue of resilience among pharmacy technicians, as well as our efforts and what pharmacists and organizations can do to build that resilience, and what does that resilience have to do with the current work environment for pharmacy technicians, as well as implications moving on for the future, including pharmacy technicians embracing new roles. So we know we got this project started with a literature review and general knowledge of what's going on out there in the world today. We know, for example, that pharmacy and pharmacy organizations have expressed some positivity toward technicians taking on larger roles in the workplace. You know, it's funny because when we first started doing this research, and when we really began to acknowledge pharmacy technicians more so worldwide, let's say just over a decade ago, there was very little literature out there. Pharmacy technicians had been doing lots of things for many, many years, and those roles had gone somewhat unheralded. And we might argue that they're still somewhat unheralded now by certain organizations and so forth. But we know we've seen a great expansion of literature. We've seen FIP, for example, create these symposia and be instrumental behind the whole concept of Pharmacy Technician Day, which we're celebrating worldwide. So I'm excited about that. But pharmacists have begun to recognize, as well as organizations, that if we're going to do the things that we say we're going to do, i.e. pharmacists are coming out from behind the counter and become more patient-centric and take on all these additional services, then the things that they were doing back then have to be done by someone else. And that person is the pharmacy technician. So thankfully, we began to ask ourselves a couple of decades ago that we need to take an examination of these personnel and everything about them, their pay, their work environment, their recognition. So pharmacy technicians have begun to take on more and more roles. And we know that this was certainly expedited by the COVID pandemic, where we saw pharmacy technicians here in the US, for example, become the epicenter of vaccinations for COVID, as well as greater technician efforts involved as a result of the increased use of telemedicine, telepharmacy, and other types of technology. We've seen some evidence thus far of technicians help their active deployment by pharmacists result in a more efficient work environment, a more camaraderie work environment. We've seen pharmacy technicians getting involved in transferring of verbal prescriptions, collecting medication histories. Really nice paper, by the way. Many of our audience may be familiar with it, perhaps not, I'm not sure. But there is a number of papers that have been published where pharmacy technicians have actually been shown to be as accurate and sometimes more accurate in collecting medication histories in both the community and in the emergency and in the hospital department settings, as accurate as pharmacists and accurate as nurses, at least, in collecting medication histories. So we know the potential is there. And as I mentioned, COVID-19 has really exacerbated, I suppose, there's a tiny silver lining in every cloud, even though it's hard to imagine too many silver linings or even consider that silver linings out of the pandemic. But it did help to exacerbate and expose the types of things that technicians can do in the hospital and the community setting. As I mentioned, vaccine administration, and also we've seen technicians who become involved in the increasing array of activities provided by the pharmacy, including point of care testing. Next. So if you look up resilience, it has a myriad definitions, whether you look at a brief Webster's type definition or more fancy definitions, if you will, longer definitions in the literature. So we start out with the basis of defining resilience as the ability to adapt to, and maintain psychological equilibrium during times of stress. In other words, your ability to cope with change, and particularly those stressful situations that we all see at work. We saw it even before the pandemic and definitely saw that multiplicatively during the pandemic. Resilience has been thought to be an avenue to mitigate burnout. So if we cope better, it's less likely we're going to become disengaged. It's less likely we're going to become tired. It's less likely we're going to become burned out. It's less likely that we're going to be very, very frustrated on our jobs. At least that's what the evidence had suggested thus far. Now, the first time, it was actually during the midst of our research that we saw this wonderful paper, and the first one that was published on resilience among pharmacy technicians. And it was a sample that was from Singapore, and it was published in the Journal of the American Pharmacists Association, and I have it referenced there. And they correlated the resilience among the sample of technicians in Singapore with age, years of experience in the profession, marital status, nationality, full-time employment status, and work hours. All of those things were related to pharmacy technician resilience. And as we might have suspected, but this study, well done study, I might add, confirmed that resilience and burnout were found to be negatively correlated. In other words, Technicians who reported higher levels of resilience were less likely to report burnout, right? So we sought to identify resilience in a sample of US pharmacy technicians, as well as look at a number of things that were leading up to resilience, as well as correlated with resilience, and what does resilience mean in the future. One of the things that hadn't been done also was really take an examination of how pharmacists lead or supervise technicians. Certainly, we've looked at technicians supervising other technicians, and we all know that the majority of technicians, of course, report to a pharmacist. And there's been a lot suggested of late about transformative leadership. In other words, leadership that's not just transactional in nature, not just telling someone what to do, saying that they did an okay job, directing them, telling them exactly how to do something, complimenting or not complimenting the informant, but transformative leadership, suggesting that you actually mentor, you actually counsel, you actually develop and grow people. So it had never really been measured previously, the extent to which pharmacists engage in transformative leadership behaviors as perceived through the eyes of the technicians themselves who are being supervised by the pharmacist. So we wanted to measure these types of things, not only their mentoring and their counseling, but talking optimistically about the future, delineating a future role for pharmacy technicians, not just one day, 1 week, 2 weeks, but even months and years ahead of time. So we're interested in that, and we see that technicians who are supervised by pharmacists who engage in more transformative leadership behaviors, we speculated are more likely to be committed to the organization and their profession, and less likely to engage in turnover, or at least have intention in turnover. And these initial hypotheses were proffered and published very recently, just in the last 2 weeks, in the American Journal of Health Systems Pharmacy. Next. So in this study, we saw that pharmacist supervisory behavior, namely transformative leadership behaviors, may be impactful to pharmacy technicians' attitudes and work-related outcomes. Ryan, go down to the next slide, and I'm gonna toggle back and forth between this one and another one. So I'd like to bring your attention to the correlation matrix. Table 4 here, which is taken directly from one of these manuscripts, and this one being the second one in the Journal of the American Pharmacists Association. So if you look at the first row, you'll see RES stands for resilience, and if you look across horizontally, you'll see the correlations that resilience has with the AMLQ, which I'll explain in just a second, CWS, which is coworker support, future uncertainty, the FUTUNC, salary and age. Now, there's a lot of information stocked in this relatively small table. So I would like to take the opportunity to go through that with you. The AMLQ is a measure of pharmacist transformative leadership behaviors. So you see a positive correlation between pharmacist transformative leadership behaviors and resilience. So in other words, if technicians see and observe and experience a greater level of transformative leadership, mentoring, looking into the future, things that we think of as leader rather than managing people directly, sort of a transactional sort of thing, we saw a significant relationship between that and their own self-reported resilience. Basically, just as important, though, is coworker support, the CWS. So if technicians receive support from their peers, their colleagues, their fellow technicians, they are more likely to be resilient as well. Now, those who are resilient are more positive about the future. So future uncertainty is a very important variable. We've measured it before as long as 20 years ago. And it is a problem among pharmacy technicians. And future uncertainty is defined as not knowing what your skills will be of great use in the current 5 years. And so this is a problem, at least in the United States, and my understanding is that it's a problem worldwide, that technicians who are not being developed by their employer, by their supervising pharmacist, really don't know their place in the organization. They're viewed as mere cogs in a wheel by a larger organization. And so it is not surprising that we see a larger amount of turnover from those technicians, because their employers have not stated that in where they're going to be in 5 or 10 years from now, and how they fit into the organizational culture and into the grand scheme of things moving forward. So those who are resilient are less likely to experience future uncertainty, that even in the face of relatively poor management, say, for example, that they are going to think to themselves, you know what, I'm resilient, and even if I don't have a clear path, I am going to see a future, and I'm going to make the best of things to come. I think it's also important to examine the relationships that are not statistically significant, because resilience has nothing to do with salary. This was not significant, and slightly to do with age. So this really makes a lot of sense and actually confirms even greater validity among our study, because the things that you would suspect resilience to be related with mildly or not related to, indeed, that was the case. And so it doesn't really matter how much a person gets paid. That doesn't really factor into the resilience. It matters how much they get paid, for sure, but that doesn't factor into the individual's resilience. In other words, giving me money doesn't make me resilient. And as the literature has shown in other industries having nothing to do with healthcare, as a person ages, they become more resilient, but relatively slowly over time. Okay. So this study found relatively moderate to strong levels of resilience among a group of certified pharmacy technicians, regardless of practice setting. And by the way, these hold for community, hospital, long-term care, and all other settings. These numbers might be a little different in each, but the statistical significance was the same in every one of them. The study found that certified pharmacy technicians with higher levels of resilience are more committed to their employers, less likely to leave their jobs, and more likely to remain within the profession. Next. So from the initial part of this study, or initial couple of phases of the study, we saw that pharmacists and employing organizations can help build resistance in pharmacy technicians. Transformative leadership behaviors by pharmacists, such as taking a personal interest, mentoring, helping people develop their strengths. I'm sure many of you have heard of strengths finders, and I'm not saying that we all need to do that our respective workplaces, but we all know that every person has a certain set of strengths. Some are better at achievement, some are connectors, some are builders, some are learners. We have all types of persons with different types of strengths. And whatever those strengths are, the best leaders are those who help build those strengths in other people. The support of coworkers and camaraderie. You know, when I say the support of coworkers, I mean that twofold, because we are finding out in this research, as well as research that I'm doing in other sampled populations, that collegiality is extraordinarily important. And that is, you know, having someone's back at work. If someone is not feeling that well, kind of picking up their slack a little bit. If someone's a little down or a little depressed at their job, picking them up. But camaraderie is also important. And when I say camaraderie, that is being friends. You can't make everyone be friends, but the research is showing more and more consistently in technicians, but frankly, outside of the pharmacy world as well, that people who get along better, people who hang out with each other after work, people who are actual friends, actually helps to build resilience and a stronger workforce. So that's something to keep in mind as you develop social programs, mentoring programs, and examine the relationships that exist at work. Those technicians with greater resilience are less likely to encounter future uncertainty, as I mentioned before. And when you encounter future uncertainty, it gives you doubt. And when you have doubt about what value, because let's face it, we as workers, whether you're a pharmacy technician, a pharmacist, a ditch digger, a labor worker, a beautician, a server at a restaurant, or a CEO, everyone at the very, very basic level wants to make sure that what they contribute to the organization is of value. And we do well as those who are supervising others to let those people know the value that they are bringing to the organization. Next. So as I mentioned, we continued with this study. This was a nationwide study of technicians in all settings. Technicians were asked to indicate the level of which they were wanting to participate in emerging activities, things that we've been talking about, like taking medication history data from patients, sterile compounding, non-sterile compounding, supervising other technicians, tech check tech. We wanted to ask them, to the extent that they were willing to engage in these emerging activities, as well as assess their level of commitment to their employing organization and a willingness to put in considerable effort on behalf of their organization, as well as stay committed to the entire profession. Next. So we see here, we measured something called technician willingness. So we examined their willingness to participate in individual activities, and that's coming up in the next slide or two. But I wanted to show you these correlation coefficients again. This one's a little bit easier to read because it's just the total willingness score to match up in correlation coefficients with each one of these things. Now, again, notice, so what we did was create a willingness score. That is, we took pharmacy technicians and we asked them their willingness to engage in about a list of 15 activities on a scale from 1 to 5. So we took the score for each of those 13 to 15 activities and we added those to create a total willingness score across all of the activities. Technician resilience was the greatest explanator, okay? That is, the highest correlation was right here. So that means of all the things that we looked at, the thing that was most highly predictive of technicians being willing to engage in new emerging roles was their resilience. We also saw a positive relationship with their willingness with the transformational leadership behaviors by pharmacists. In other words, if they receive direction from pharmacists, they are more likely to want to engage things because they think, hey, look, in 5 or 10 years from now, pharmacy is probably going to be doing a lot more of these things. This will be of value to me. My pharmacist is developing me. My peers are supporting me, as you see here. And thus, I'm willing to take on these responsibilities because I've been told that in 5 or 10 years from now, this is more what I'm going to be doing. We also saw a correlation between their willingness and their commitment to the organization. We also saw a negative correlation between future uncertainty and their willingness to engage in these activities. In other words, if they're not certain about the future, they're not as willing to engage in these emergent activities. And as I mentioned before, there's basically no, and the asterisks indicate the level of statistical significance. There was no difference between, there was no correlation between salary and resilience. This is not by any stretch an advocation of not paying pharmacy technicians, just the opposite. In fact, all the things that we publish talk about career laddering and paying technicians. The point being is that the salary does not really predict anything. It's just something that needs to be done. And again, we actually saw, now here we saw that the older technicians were less likely to undertake who wanted to take on new responsibilities. So the younger technicians were those who were more recently trained, probably more recently certified, and thus they are more willing to take on these new roles. Okay, next. And there you see the individual, our table 1 from this publication in Research in Social Administrative Pharmacy. This was on a willingness score. So basically, that summary of responses was the score that I went over the correlations with just a moment ago. And there you see pharmacy technicians in all settings combined were most willing to take on medication history data collection, billing and reimbursement, supervising other technicians, prescription transfers, and pretty high for tech. Even on the lower end, they were still relatively positive about taking on new roles, but they were less positive about administering vaccines, point of care testing, and sterile compounding. Probably indicative of the fact that the fewer technicians are involved in these activities, and they feel a need for more training in these areas. Next. So as I start to wrap things up here, we have lessons learned and recommendations for the future. Pharmacists, pharmacy technicians, and peers and organizations can contribute to an organizational culture, because ultimately that's what we're studying. We're studying a culture, and culture is not created by a CEO. Culture is created by every single person, no matter who you work for, whether you work in the US for a Walgreens, in the UK for a Boots, or whether you work for a large pharmacy organization, everyone contributes to culture. And in doing so, they may serve to invite pharmacy technicians. They encourage commitment, we encourage resilience, and we encourage a willingness to embrace new or emerging responsibilities among all of us. And so while pharmacists have a responsibility, we all have a responsibility to try to contribute to that organizational culture and build and support one another to the extent that's possible. Next, Ryan. And that's just a list of references there. We had our background from some really nice papers that have been published in Research in Social Administrative Pharmacy, as well as the Journal of Pharmacy, as well as the Journal of the American Pharmacists Association. And I would just encourage all of our participants to take a look at these and take a look at the emerging literature. Certainly look at our papers, of course, which is references 7, 8, and 9 that are just now out. But take a look at the greatly expanding literature in the last decade, even the last 3 or 4 years, of all that is going on with pharmacy technicians out there. And again, we are so excited about pharmacy technicians taking on these new roles, being recognized, hopefully being paid, hopefully having their organizations creating career ladders for them, and all of us supporting one another to move the profession forward. So thank you for your attention to this part of the presentation, and for letting me kick off the day with you today.
Shane, thank you very much. That was very insightful. And I know I have a kind of a long list of questions for you when we get to the Q&A session. And, in particular, one of the things that you mentioned toward the end about culture being created by everyone in the organization really resonated with me. And I hope that after Allison's presentation, we can spend some time discussing that a little bit as well. So thank you again. Our next speaker is Allison Hemsworth. So Allison is a UK pharmacy technician registered with the General Pharmaceutical Council. She trained in hospital, but has since had a very diverse and possibly unique career. Until recently, she had a national role with NHS England and NHS Improvement, where she led on many high-profile national projects and policy developments relating to community pharmacy. The most notable one being the introduction of the community pharmacy seasonal flu vaccination service in England. Alison now works for Community Pharmacy West Yorkshire, an organization which represents all pharmacy contractors in the West Yorkshire area when negotiating locally commissioned services and making implementation plans for the rollout of nationally commissioned services. I would also like to mention that Alison has been nominated for a number of leadership awards in the profession and is heavily involved in a number of professional organizations, both in the UK as well as internationally. And in particular, Alison is the founder and chair of Pharmacy Technicians International. So Alison, thank you very much for being here with us today. I will turn it over to you.
Thank you, Shane, and welcome everybody. And it's lovely to have you all here today. So I've been asked to speak to you today about the UK perspective of the roles played by pharmacy technicians during the COVID-19 pandemic. Next slide, please, Shane. So I thought I'd give you a little bit of background, first of all, about what it was like to be a pharmacy technician in the UK prior to the pandemic, because some of it was similar to what Shane's just described, where pharmacy technicians are in the US, but some of it was quite different. So pharmacy technicians in the UK have been a regulated profession for many years, and the phrase pharmacy technician in the UK is a protected title in statute. So what that means in reality is that you can only call yourself a pharmacy technician if you are on the General Pharmaceutical Council's register. And if you're not on that register and you choose to use that title, you are effectively committing a criminal act. And that was a pivotal moment for us when that voluntary register opened in 2005. And then the mandatory register opened in 2011. So since 2011, in order to practice as a pharmacy technician, you have to be on that register. I was quite amazed when Shane said that they had 283,000, Ryan said that they had 283,000 pharmacy technicians certified via PTCB in the States. We've got approximately 25,000 pharmacy technicians from the whole of the UK on the register, which is about half the number of pharmacists in the UK. So a significant difference in numbers there. And I think my colleagues from the UK who are on this call would wish that we'd got that 283,000 number of members. Because of registration, the roles of pharmacy technicians in the UK had already significantly expanded beyond the traditional roles of dispensing, especially in the managed or the hospital sector. So to give you just a flavour of what that looked like even prior to the pandemic, we have pharmacy technicians who are associate directors of pharmacy in hospitals. We have clinical pharmacy technicians both in the hospital sector and the GP practice sector, and there's rapidly growing numbers of those, and equally there are rapidly growing numbers of qualifications that they can now undertake and attain to demonstrate that they are clinically competent. We have pharmacy technicians in community pharmacy delivering point-of-care tests such as hepatitis C, and in all sectors, pharmacy technicians are performing medicines reconciliation, which is more than just drug history taking. My personal role at the start of the pandemic was head of primary care for pharmaceutical services in the national team at NHS England, and I had responsibility for developing the community pharmacy policy in England, designing new community pharmacy services, participating in negotiation of those new services, and writing service specifications so they could be implemented across the country. I was really interested in listening to Shane's research, particularly about the transformative leadership aspects from pharmacists. Until last year, I personally hadn't been managed by a pharmacist for over 11 years. In my new role, I am managed by a pharmacist, but I'm just telling you that to give you a flavour of where we're moving towards in the UK, because it is quite different. Certainly in a hospital, most pharmacy technicians are probably more likely to be line managed by a pharmacy technician than they are by a pharmacist at the moment. Next slide, please. So again, at the start of the pandemic, so the General Pharmaceutical Council, which is the regulator for pharmacists, pharmacy technicians and pharmacy premises in the UK, they have those regulatory powers via a piece of legislation called the Pharmacy Order 2010. And right from 2010, those legislative powers enabled the GPHC, if they needed to put in place temporary registers to manage national emergencies such as a pandemic. So in March 2020, the temporary register opens for pharmacy technicians and pharmacists, and it was an opt-out model. So basically what they looked at was all the people that had left the register, either voluntarily or had decided not to pay their fees for the previous 3 years, and enabled them they told them that they were going to put them on this temporary register, and if they didn't want to work as a pharmacy professional during that period of time, then they needed to opt out. Importantly, anybody that was subject to or had been had a negative outcome of a fitness of practice issue or an investigation was not on that temporary register. So we had a mechanism by which to get people back into the two professions at the times of a national emergency. So on the day that temporary register opened, there were 2,909 pharmacy technicians remained opted into that temporary register. So that was just short of an extra 3,000 pharmacy technicians that were then able to come back into the workplace and work to help with the pandemic efforts. And the General Pharmaceutical Council did a survey around about the same time that showed that most of the temporary registered pharmacy technicians plan to work in either a hospital or a community pharmacy setting, which makes sense because most of the work at the time of the pandemic was to ensure that patients still had ready and quick access to their medicines by their prescriptions. Initially, that register was supposed to end on the 30th of September this year, but right at the last minute, the UK government asked for that temporary register to remain in place until 2024. So they clearly think that the need for those extra people is still there for the foreseeable future. Next slide, please. So obviously, vaccination was a huge issue during the pandemic, certainly once the vaccines themselves were available from the beginning of January, from the beginning of 2021. That presented a little bit of a problem in the UK in terms of the numbers of people who were legally able to vaccinate people. So outside of a pandemic situation, there are routes in the UK to supply and administer prescription-only medicines without prescription. And obviously, all vaccines are prescription-only medicines. So we have independent prescribing, and pharmacies can undertake this post-registration qualification to be an independent prescriber. And in actuality, from 2026, all newly qualified pharmacists in the UK will qualify as independent prescribers from day one of their practice. We then have something that's set by legislation called patient group directions. And this identifies a group of patients, for example, those who are eligible for a free flu vaccination, and allows registered professionals from a statutory list to supply or administer that medicine to eligible patients. Pharmacists were on that list prior to the pandemic and therefore were already vaccinating people for flu and were already very quickly able to start vaccinating people for against COVID as well. However, pharmacy technicians weren't on that list and at the moment still aren't on that list, but I'll come back to that in a moment. We then have a more informal way of doing things, so no legislation, which is called a patient-specific direction. And in essence, this is where a prescriber, usually a GP, identifies specific patients and delegates the administration of a medicine to a specific set of people. So a pharmacy technician could work to a patient-specific direction, and in hospitals and GP practices, that was a very emerging practice. I've seen people say hello on this call already, and I can see that there's some people that are working in those settings in the UK who are absolutely vaccinating people for flu using a patient-specific direction prior to the pandemic. However, at the moment in community pharmacy, most community pharmacists are not independent prescribers, and therefore to then ask very busy GPs to start to write these patient-specific directions to enable community pharmacy technicians to vaccinate people was too unwieldy. And because they just didn't have the time to do that. So although that was there right at the start of the pandemic, it was not necessarily the most efficient route to enable pharmacy technicians to be able to vaccinate in mass vaccination centres during the height of the pandemic. Next slide, please. So I mentioned their patient group directions, and this is just to give you an idea of how long it takes to get legislative work through. I'm guessing everywhere, but certainly in the UK. So in 2014, it was agreed in principle that it was a good idea to enable pharmacy technicians to be able to work, or potentially be able to work to patient group directions, subject to consultation, legislation, etc. It took 3 years for the case of need to be pulled together and submitted to the relevant bodies, the NHS in England, and also to the UK government. By the time the start of the pandemic hit, we still hadn't seen any progress on the movement of that case for need, predominantly because other professionals were also asking to be on that statutory list to be able to administer medicines via patient group directions. So it was just a case of we hadn't got near enough towards the top. So in 2020, at the start of the pandemic, a paper was submitted by our professional body, the Association of Pharmacy Technicians UK, to the relevant stakeholders, outlining the urgent need for pharmacy technicians to be able to vaccinate in an efficient manner. We still haven't quite got there in terms of patient group directions. However, about 6 weeks ago, we did have an announcement that there will be a public consultation on whether pharmacy technicians should be allowed to work to patient group directions. That hasn't been launched yet. We're hoping to see it fairly soon. But even once that consultation's happened, it then needs to be reviewed to understand what the mood of people who have responded to feel. And so we still don't know when and if it will become a reality. Next slide, please. However, it was recognised there was an urgent need for not just pharmacy technicians, but other healthcare professionals, and actually people outside of healthcare professionals were able to join in and being able to vaccinate people. So there was a significant amount of political reasons as to why we couldn't just expedite the use of patient group directions at that point in time. I won't go into those, but we came up, or the UK governments came up with a new type of mechanism, which is called a national protocol. Initially, this was just for COVID vaccines, but it's now been extended to the provision of flu vaccination as well, because clearly those two respiratory illnesses are quite closely linked. And what a national protocol does is it sets out who can do what in terms of the vaccination process, because quite often it's a split process. So broadly speaking, it enables registered staff to be able to take clinical consent for a vaccination and administer it if they so wish, and it enables non-registered staff to be able to actually administer the vaccination. However, for pharmacy technicians, there was a little bit of an anomaly, because if they didn't, we are registered in the UK, but if they'd enabled us to take that clinical consent, that would have been contravening the existing patient group direction legislation. And this was intended to be a temporary solution, and so that wasn't an option. So in terms of pharmacy technicians, although we are a registered profession, we are viewed under the national protocol as a non-registered profession and therefore can administer the vaccine, but we can't take the consent of the patient and check that the patient is eligible and it's safe for them to have a vaccination. So in many mass vaccination centres, that meant that they didn't actually use pharmacy technicians because they didn't have the space and capacity to split that process up. In lots of other mass vaccination centres, they were used, and a clinician would take the consent and then pass them on to other people, such as pharmacy technicians, to actually administer the vaccine himself. But they weren't as widely used as they perhaps could have been. But the good news is that we are now vaccinating in mass numbers by pharmacy technicians. Next slide, please, Ryan. So, I also thought it was important to mention the other contributions to the pandemic by pharmacy technicians. So many pharmacy technicians took on senior leadership roles of overseeing the management of mass vaccination centres as vaccination hub site managers, and they pretty much never slept the entire time that they were doing that, because those centres were open not quite 24 hours a day, but near enough. and they were predominantly led by people like pharmacy technicians. A smaller number, but still a large number of pharmacy technicians contributed towards the setting up of what we called Nightingale hospitals. So in the UK, there was a bit of a worry at the start of the pandemic that we'd run out of space for people in hospitals who needed to be hospitalised, but due to COVID infection. And so the concept of Nightingale hospitals was brought about. In essence, there were field hospitals. So in many cases, there were conference centres that were taken over, the field hospitals set up within that conference space, purely for the treatment of patients who needed hospitalising as a consequence of COVID vaccination. But people like pharmacy technicians walked into those conference centres on day one, and it was a conference space. And by the end of the week, it was a fully functioning hospital. And those pharmacy technicians led the design and setting up with a dispensaries, procurement, etc. So huge involvement there. An even smaller number, but nevertheless still significant, other pharmacy technicians became involved in controlling the UK government's medicine stockpiles using their medicines procurement expertise. So clearly an important role to make sure that medicines that the UK government owned were able to be moved to the places that were needed in an expedient way. Similarly to the research that Shane's just described, the University College of London are currently conducting a study on the range of activities that pharmacists and pharmacy staff, including pharmacy technicians, contributed to during the COVID-19 pandemic. So at some point in the future, we should have an even deeper understanding of exactly who contributed and what their contribution was to the pandemic. Next slide, please. So Shane quite rightly highlighted that there's a direct correlation between resilience and burnout. And burnout amongst pharmacy professionals, and what I should have said at the beginning is that term pharmacy professionals in the UK means pharmacy technicians and pharmacists. And as a consequence of the pandemic, we've seen high numbers of burnout amongst pharmacy professionals, but particularly in community pharmacy. And that was because in the UK, a lot of other primary care services, such as GP practices and dentists, closed their doors to patients. Dentists didn't see patients for several months until a way was found for them to be safe to deliver services. GP practices did continue to serve patients, but in the main, a significant amount of that work was done online, and they only saw patients face to face where they actually absolutely needed to. So community pharmacy teams suddenly found themselves faced with undertaking tasks that had previously been undertaken in a GP practice, such as blood pressure monitoring. And initially, patients were ringing their GP practice saying, I'm on an antihypertensive medication, I need my annual blood pressure monitoring, can I make an appointment, please? And GP practices were saying, we can't take you at the moment, but if you pop along to your community pharmacy, they'll be able to take it for you, which they could, but at that point they weren't commissioned and therefore not paid to provide that service. However, the good news is that whilst that service was initially unfunded and community pharmacists did provide it, that has now become a nationally commissioned service from all community pharmacies in England. It's currently a pharmacist-led service, but due to recent announcements at the end of September, we now know that hopefully by the end of this calendar year, that pharmacy technicians will be able to deliver that service imminently. So another new service for the profession there. Next slide, please. So when I was fortunate enough to see Shane's slides ahead of everybody else, so that I could make sure that my slides followed on from his. And I think his work is really interesting. And given what I've said previously during this presentation about the fact that significant numbers of pharmacy technicians in the UK are led by other pharmacy technicians, it will be wonderful if at some point in the future we could see whether that makes any difference to those resilience levels, hopefully increasing them, but who knows? But that just might be a different nuance. But we also know, due to anecdotal information, certainly in the UK, that working in professionalisation is also another known cause of lack of resilience. And community pharmacy technicians in particular tend to find themselves working in professional isolation. Generally, most community pharmacies in England, if they have a pharmacy technician, only have one. And so they're absolutely working in professionalisation in terms of not working with other pharmacy technicians. And so another way of trying to increase and support resilience is to create networks to reduce that professionalisation, isolation. Pharmacy technicians have, over the last, 5 to 10 years, have been quite good at setting up networks in the UK for themselves, and they're constantly evolving. But at the moment, they do tend to be sector-specific, and certainly in England, we're all being directed to work in an integrated way now, so that the patient's seen holistically. And so sector-specific networks are not necessarily conducive to that method of working. However, as I say, it's an evolving process. But I personally looked at what was going on and could see there was a distinct lack of international pharmacy technician networks. And so it's difficult to understand what good practice of pharmacy technicians looks like across the world, and if there is indeed any standardisation between some of that good practice. Next slide, please. So in the role that I was in at the start of the pandemic, my job description actually said that I needed to be able to understand and implement international best practice. And so inspired by that, and to be able to demonstrate that I could meet that, I thought about, how I personally might be able to do that, and how I personally might be able to help other people to do that. And actually, the COVID pandemic brought an opportunity there, because very quickly the world started using greater use of online meetings like we're meeting today, both not just the meetings but for symposia, conferences, etc. And it created an opportunity to network in a different way. So having reached out to pharmacy technicians in other countries prior to the pandemic, I then invited a few of them to join me to form a steering group. And over the course of about a year, we looked at what could we do, what have we got capacity to do, and at the end of that, this literally a year ago today, we launched Pharmacy Technicians International, which is a global community of practice of pharmacy technicians, so a very different organisation to FIP, and the two complement each other. So our global community of practices is about enabling pharmacy technicians to talk together, to understand, if you perform this role in the UK and there's a similar role in the US, are you working to similar standards? Are there any standards? Does this role exist elsewhere? If it doesn't, would you like it to exist, and how can you learn from each other? And we have a terms of reference, and there are two key themes to that. One is about ensuring that pharmacy technicians actually start to understand that one of the key aspects of being a profession, and a regulated profession in particular, is that you need to start researching your own profession. Broadly speaking, there are virtually no pharmacy technicians who are researching our own profession. There's a very small number, but compared to the number of pharmacists who are in academia, it's minimal. And so our first 6 events in the first 3 months of launching were about encouraging pharmacy technicians to understand what research is, and to consider whether that was a future pathway for them. And we started out by saying this is what research looks like. We then gave an opportunity to a pharmacy technician who is a researcher to come and tell us a little bit about her work. And then we had 4 opportunities where people could dial in and listen and ask questions of 4 other pharmacy technicians from around the world who are all currently researchers, so they could understand a little bit about it. And then we've also since run 3 international events around particular clinical areas. So we've looked at asthma, autism, and ADHD, and dyslexia. Again, to try and understand the role of pharmacy technicians in those 3 clinical areas across the world, and it was being a really interesting experience. I think that's my last slide, apart from a set of references. Yes, there we go. So yeah, I'm also looking forward to answering any questions that you may have. Thank you for listening.
Alison, thank you. That was very informative, and I just want to commend you on the work that you've done to help try to end some of that professional isolation that you mentioned. And I think your point about research is very interesting, especially given that there are lots of opportunities for new research, and having technicians involved in that seems like a common sense thing that we should do. And so I appreciate that you've taken the lead in trying to inspire people to do that. So thank you.
Thank you.
So with that, we do have about 15 minutes for questions from the audience. And so I'd like to encourage you, if you have questions for either of the speakers, to please begin entering those in the Q&A box that is on your screen. To get us started, though, I do have a few questions that I'd like to ask of both of you. And the first is really about what Shane brought up in his presentation around transformational leadership qualities. And so my question is, how do people obtain those qualities? Is it through training? Is it natural ability? Is it something else? What is your experience in that area? And maybe what advice do you have for people that want to amp up their own leadership abilities?
Thank you, Ryan. I'm so glad you asked that question, because we hear so often people use phrases like born leader and things of that nature. And there are people with talent, but that doesn't mean that they're a born leader. There are people, for example, with athletic talent, but that doesn't necessarily have them playing professional ball. You've got to do much more to leverage that talent. You don't just appear in the playing for an English Premier League soccer team or United States NFL team in American football by merely having talent. So it is learning, and it is one of those things, and even coping mechanisms, even things like some of the other things I talked about today, like how do you build? So we talked about organizations building resilience, but you can build your own resilience. There are myriad ways that you look at. Some of it is written in very lay language that you can read in self-help books. Some of it is in the literature to guide us that is in peer review. But definitely you can hone your leadership skills. Those opportunities are vast. They come from very expensive and they range from things like Harvard courses that are open to the public, all the way to things that you can simply read on the internet on your own. So you can definitely build your leadership skills. It is mostly not just something that we were born with, and obviously, but one of the things that I want to mention is we started saying a few years ago, Ryan, that one of the important things about pharmaceutical care was the care. People were often, it was the pharmaceutical part. No, actually, it's the care part. And you'd be caring about others is probably the thing that leverages your talents most into those transformative leadership behaviors. Taking a genuine interest in someone, putting them under your wing, developing them, and watching them grow. Many people fortunately are at the stage of their career where I get a bigger kick out of seeing someone who has worked with me accomplish than yet another paper for me or what have you. And I think when you have that sort of mentality, that is what leverages your leadership. It's not some sort of, the more individualistic you are, in fact, the less likely you are to be a leader. So I think those are the really important things to take home. And we saw, like I said, culture impacts everyone. And even though transformative leadership behaviors are extremely important, our research saw that coworker support and the support of your peers is every bit as important as that from your supervisor. So it's really important to be camaraderous, to try to get along, and to support one another, each other professionally and even socially.
Thanks, Shane. Alison, do you have anything to add to that?
I do, yes, although it's quite similar to Shane. So I'm one of those people who've been fortunate to undertake a master's in leadership and development in health and social care. And day one of that course, the most important thing that I learned is that a manager is not necessarily a leader, because in the English lexicon, they quite often are, they're interchangeable, those words. you can be a manager, but you're not necessarily a leader. They are different skill sets completely. And so because if you've got a badge that says you are someone's manager, that does not, as Shane said, that does not necessarily make you a born natural leader. Something that's certainly arisen more in the UK during the pandemic is the notion of compassionate leadership. And, if you are not someone who can ensure that your staff are psychologically safe, then how on earth are you going to enable your staff to make sure that their patients are psychologically safe as well? So that compassionate leadership, it might not be a direct patient care thing, but it impacts upon patients ultimately. And for me, after 35 years of being a pharmacy technician, I get asked to do these sorts of things all the time. And when it's appropriate, like today, I do that. But more often than not now, what I say is to people when they ask me to speak is, actually, what do you really need? And when they tell me that, and I go, actually, it's not me that you need, it's this person. So I'm shining a light on others to demonstrate that, the world's not just about a very small number of people who can stand up and speak about a particular profession. There's lots of us out there. And actually, we need to do that because they're the leaders of the future. And if we don't give those opportunities now, they might miss out on them.
Thank you, Alison. You said something sort of in the middle, I think, of your presentation as it relates to legislation and the need to play the long game. And I think we certainly experience that here in the US, right? It can take a very long time to make change. How do you keep yourself or those around you motivated or inspired to keep pushing when it takes, maybe a decade or more to get the change that you're trying to make?
Yeah, that is really difficult. Really difficult. Sometimes, sometimes things happen and there's good signs that it's going to go your way and then it doesn't, and that can be quite demoralizing. And I'm sure it's the same in other parts of the world. Very often, it's a very small but powerful group of people, wherever they come from, that actually derail what you thought was the direction of travel. But for me, the thing that keeps me going is knowing that it's the right thing to do for the profession, and it's also the right thing to do for patients. And so I haven't been patient facing since 2001, but I know that everything that I do on a daily basis at some point has a direct impact on patients. And it took me a long time to recognise that fact. I kept challenging myself, should I go back into direct patient care? And then I realised, actually, although I don't see it on a daily basis, I am doing it. You just need to be able to correlate your work to that impact.
Thank you. Shane, is there anything from your research or experience that you want to add as it relates to keeping people engaged to play the long game, as Alison said?
Yeah, and I'll just point back to what I mentioned, Ryan, and I know I emphasized it in my talk, but I want to reiterate that opportunity. Everyone wants to feel as though they are valued. It is such the most basic thing that all employees want, and what some people, I think, lose sight of is that we think that it is only certain people, particularly white-collar professionals, who are those that are interested in advancing, those that are interested in having some sort of future, those that are planning or trying to plan 10 and 15, 20 years down the road for their profession, their selves, their family, and it's all of us. It's pharmacy technicians, it's fry cooks, it's pharmacists, it's CEOs, we're all doing it. And so I think when you keep in mind that everyone is interested in the long game. I mean, I listened to Alison's presentation, and I'm just so excited to hear about the Pharmaceutical Council. In fact, she's going to get a bunch of emails from me in a little while. She didn't know that yet.
Likewise.
when you remember the fact that everyone is interested in the long game, not just you You will bring so many people with you. You will bring legislators with you. You'll bring technicians with you. You'll bring educators with you, researchers with you, pharmacists with you, FIP with you. You will bring all of those people with you if you remember that everyone's concerned with the long game, not just yourself.
Yeah, we are very much all in this together.
Absolutely.
Alison, we did receive a question for you. How much engagement have you received since launching Pharmacy Technician International?
Yeah, that's a great question. Thank you to whoever asked it. So this time last year, on the day we launched, there were 7 of us and they were all the steering group members. As of this morning, because I've looked because it's a year since we launched, we have 1,630 members from 45 different countries. So predominantly, a lot of those are in the UK because that's where my networks are, but it's growing numbers everywhere. We would dearly love to have other people join us. The only criteria you need to be able to join is that you're either a pharmacy technician or someone who's training to be one. So that's measurable numbers. But we also have Twitter and LinkedIn accounts, which obviously is not as easy to measure. So, but a much bigger impact than what we might have anticipated a year ago.
Congratulations. That is
a
very significant increase in members and engagement in just a year. So shifting gears a little bit, Shane, one of the things you mentioned in your presentation was about technicians and their accuracy as it relates to medication history. And I know that we've also seen in the literature the accuracy of technicians compared to pharmacists on things like product verification as well. So one of the questions that I sometimes hear people ask is, why is that? Is it training? Is it fewer distractions for the people who are engaged in doing the product verification of the med history? What has got us to this point where technicians and pharmacists are sort of neck and neck when it comes to their ability to perform those tasks?
Well, I think there's a couple of things at play, Ryan. I mean, one, so the technician's responsibility, at least in the US, is not as multifold, if you will, as pharmacists. So they are able to dedicate that time, that energy, and that interest toward this particular activity. But secondly, I think that we've also seen a shift in how pharmacists are improving their delegatory authority, improving their delegation skills to technicians. They're embracing more of technicians being able to do these things. And thus it is building the self-efficacy and the confidence in the technicians to be able to do so, as well as, and I'm not just saying this because you're here, as well as the continued recertification and the continuing education credit hours that are being offered by organizations like PTCB to increase the level of competence of pharmacy technicians that go well beyond just them entering the fold. So we see the whole technician space professionalizing, as we saw pharmacists professionalizing decades ago. And part of professionalization is that continuing education, that self-help, that self-efficacy attitude, and just organizations and supervisors putting faith in you. So when somebody puts faith in you, you're gonna do better. So I think technicians are taking upon themselves. I think their organizations are helping them. And I think, of course, that their tasks are more dedicated rather than multimodal in nature, and it allows them to do the sorts of things that they're capable of doing. So I think we need to continue focusing our energy and efforts and education towards technicians, but also towards pharmacists and other supervising technicians, as is the case, for example, with Alison in the UK and some of the other countries. Anyone who is supervising those technicians to be able to increase their competence in delegating, because there is an art and a science to delegating. And so that's incredibly important. So I think it's a confluence of factors, Ryan.
Thanks. Alison, was there anything that you wanted to say on that?
Yeah, I think generally speaking, pharmacy technicians are very detailed people naturally. So I've got a granddaughter who's nearly 3. So she's at that stage where she's asking, but why? And I can cite several occasions in my career where I've stood talking to a pharmacist and I've gone, but why? But why? But why? I want to get to that level of detail, and I think having that ability to get to that level of detail and accuracy, because with detail comes accuracy, then I think that's one of the contributing factors towards how the research found what it did. And if you ever send me a report, I will skim read it and proofread it very quickly and tell you where all your spelling mistakes are.
So Alison, I do have just one last question for you before we wrap up here, which is, you mentioned that I believe in 2011 is when there was mandatory registration. Is that correct? Can you share briefly what it took to get there? Because that's certainly not the case here in the US, and I know in many other parts of the world, not the case where there is mandatory registration everywhere for pharmacy technicians. Was there something in particular that got the UK to that point?
So our professional leadership body, the Association of Pharmacy Technicians, was founded in 1952 with the pure intent of getting pharmacy technicians to be a registered and regulated profession. So it took from 1952 to get to that point. So again, sheer persistence and collecting the evidence to demonstrate that it was the right thing to do. And initially, when it was agreed that we would become a regulated profession, it was supposed to happen in 2005. And then, as always happens when legislation's involved, something comes from left field. It wasn't a pandemic at that time, but it would have been something quite serious that took up parliamentary time. And so in the end, just the voluntary register opened in 2005, and it took another 6 years to get to the point of it being a mandated register. Yeah, a significant amount of lobbying and effort behind that.
Yeah, that is certainly the long game.
It certainly is.
Thank you. Thank you for sharing that. Well, Shane and Alison, on behalf of everyone here, I want to say thank you again for sharing your expertise. Shane, I know we are very grateful for all of your work and research in this area. And Alison, like I said earlier, I just want to again commend you on your leadership in this area with Pharmacy Technicians International and really pushing to help bring people together in the pharmacy technician space. So thank you both again for being here. We're going to take just a moment to transition to our next session. So with that, I'd like to welcome Tamara, who will be leading the next discussion with 3 excellent speakers. Alison and Shane, thanks again.
Thank you, everyone. We're so happy that you're all with us. We will be starting our next session in just a few moments. So bear with us, stay in this symposium. We still have another session, and we'll be glad that this session will be starting in around a minute. we'll be having Tamara that will be sharing this session, and she will be navigating you through the slides and also presenting the speakers. Thank you, everyone. Tamara, you may start.
Hey, everyone. Not quite sure why I'm looking like a ghost. Let's try again.
Tamara?
Yes, I'm here.
We're live. Yeah, thank you. Perfect.
Good. Oh,
Yeah.
that looks much better. Well, welcome all of you. I hope many of you are still with us for the second session of today. And just a quick recap. We had Susan James opening this event and followed by a glowing speech from Catherine Dugan from FIP. But in a nutshell, it was all about let's celebrate Pharmacy Technician Day today, because that's actually what it is today, International Pharmacy Technician Day. Woohoo! The first session contained of 2 talks. We had a very informative and detailed talk by Shane DeSalle on leadership, and we had an almost moving talk by Alison Hemsworth on the pharmacy technician contributions to the COVID pandemic. And she really made a call to get together as pharmacy technicians and really build on the profession. But in the upcoming hour and a half of the second session of today, we also have some very interesting talks for you. Talks on the unique roles and contributions of pharmacy technicians. And it really pleases me that 2 out of our 3 speakers of today are actually pharmacy technicians. Okay, so let's go to the next slide. Before we get into our talks, just quick setup and make a connection in this digital pixel world. I'm Tamara Keuler. I'm speaking to you today from the Netherlands. I'm trained as a pharmacist, and I'm currently working as an assistant professor at one of the pharmacy faculties here in the Netherlands. I was fortunate enough to combine my love of pharmacy with my love for teaching in a PhD trajectory on the up-and-coming profession of pharmacy technicians. So it's great to have you all here today and join me in our 3 talks. First of all, some small announcements. This webinar is being recorded and live streamed via YouTube. And if you want to watch the recordings, it's going to be available on the website of FIP. If you've got questions for our speakers, please use the question box provided. You can see it down below in your screen. And you're very welcome to provide feedback on the sessions of today and tomorrow. And if you want to become a member of FIP, that's also a possibility, of course. Then also have a look at the website and look up the membership registration. So for today's program, like I said, we have 3 talks. We're going to talk about the community health workers. We're going to talk about medical safety, and we're going to talk about de-prescribing. All very interesting talks, especially since they're all related to the pharmacy technicians. After our 3 talks, we have plenty of room for questions from the audience. So please take that opportunity and discuss anything you want to discuss with the speakers. The learning objectives for today. It's all about identifying the unique roles pharmacy technicians can take on. After today, we hope to give you a clear image of the education and training pharmacy technicians might need to embrace those new and unique roles. And after listening to the talks, you might even recognize some key tasks and responsibilities of pharmacy technicians within the pharmacy workforce. Without further ado, our first speaker, all the way from the United States. So Jake had to get up very early this morning. As you can see from his bio, Jake is one of those pharmacists that combines a lot of tasks and jobs. And today he will enlighten us on community health workers in the United States. Jake, the floor is yours. If you want the next slide, just let me know.
Awesome. Thank you very much. So I want to start with the dirty little secret that is in healthcare in the U.S. right now, and that is we spend a ton of money and we have really poor outcomes. And I'm sure this international audience might kind of be aware of how much money the U.S. spends, but to get into the nitty gritty, we spend about $4.1 trillion or $12,000 per person. If you actually look at like the big data, this is more money than other countries spend in totality. It's a ton. And there's so much pressure in the U.S. around medication costs and so much emphasis on the cost of medications. And we always kind of put this blame on medications. But I want to reframe that and point out that 1.3, so about 25% of total healthcare costs is all about hospitalization. We spend $1 trillion on the administration or the paperwork of healthcare, and then we spend about $350 billion on medications. So we spend arguably 3 times as much money on the paperwork of healthcare in the U.S. than we actually do on medications, which is still 4 to 5 times as much than we actually spend on hospitalization. So we spend all of this money and we spend all of this time blaming drugs for the rising healthcare costs, but it is significant, but it's insignificant relative to everything else. And what's worse is even though we spend $350 billion directly on medications, we spend over $500 billion in the U.S. on inappropriate medication use. Really good example, my daughter is 10 months old. We've had 3 ear infections since we've started daycare because that's what happens. And 2 out of 3 of those antibiotics have actually been dosed wrong. And so we spend more money on the wrong dose and the negative outcomes associated with that than actually the money we spend on medications. So the dirty little secret within like the pharmacy world in the US is that we spend more money on the consequences of non-optimized pharmaceutical care. So if we want to change practice and elevate the role of pharmacy technicians and pharmacists in the profession, we have to start thinking about how do we focus not on is the right pill from the big bottle to the little bottle, but rather is this the right drug for the patient for the right reason, for the right indication, and all the different rights that we talk about. So it's all about making sure that it's appropriate medications for the patient. May we have the next slide? Thank you. So what's even worse is we just spent all this time talking and dispelling the myth about rising drug costs associated with bad health outcomes in the U.S. Ooh, can we go back one? Perfect. And so there's a term that I want to highlight, and it's called social determinants of health. This really is health equity, and it's the new driving force in the U.S. We see this within how hospital systems are being judged for quality. We see this with accreditation standards. We see this really permeating all of healthcare, which is health equity, the social determinants of health, because we've recognized that 20% of a person's health and well-being is driven by access to care and the quality of services provided. So in the last slide, we just talked about the quality of pharmaceutical care is poor in the US. But now on this slide, I'm highlighting that even though that quality is poor, that's not the major driver towards someone's poor health outcome in the US. 80% of a person's health and well-being is related to their physical environment and driven by social and behavioral factors. What is their education? Do they have a job? Do they have clean drinking water? Can they afford transportation? Are they able to sleep? So all of these things are social determinants of health, and they fall within this confines or this definition of health equity, and they drive the health of a community. And so may we go to the next slide? And we see where the U.S. has a lot of misaligned spending. So this is kind of combining the last 2 slides into one. The U.S. spends a lot of money on medical services and very little money on healthy behaviors and everything that makes us healthy. And so when we want to address the health of our nation, we need to get into our communities, we need to engage with our local resources, and we need to help patients where they live, not just by giving them a medication or calling them and saying how you're doing. And we can see some of the statistics for poor social determinants of health. A 5-mile difference can account for a 20-year life expectancy in some cities. So I live in Birmingham, Alabama, but let's pick Miami, Florida, right? Everybody knows Miami. There's lots of songs about Miami. 5 miles in Miami, which is still Miami proper, but different zip codes. Someone born 5 miles apart has a 20-year life expectancy difference. If someone has difficulties with their housing, so they're housing insecure, they're not sure that they have housing, they visit the emergency department 5 times as much as someone with stable housing. There's over $77 billion, which, by the way, that's about a third of what we spend on medications, on medical expenses attributed to food insecurity, just not having food. Social isolationism, so being lonely, is as damaging as smoking 15 cigarettes per day. And over 3.5 million Americans miss or delay medical care due to transportation, which accounts for $150 billion per year. Again, that's half the amount of money we spend directly on medications. And so when we think about how do we start to shift practice in a community pharmacy setting, it's how do we leverage our pharmacy technicians in a new and different way. If we go to the next slide. And this gets us into the social determinants of health and health equity. The Centers for Medicare and Medicaid Services, which is the largest single payer in the US, but not the largest payer segment, has stated that starting in 2023, specifically around 2024, any patient or all beneficiaries of CMS, which is a large percent of the US population, is going to need a social determinant of health risk assessment. And it's to really better identify the barriers to a patient's health that are affecting how well that health is being delivered. And so our goal here is how can pharmacy practice change and start to address these social determinants of health? Because when you do a social determinant of health risk assessment, you're asking someone, are you able to afford food? Are you having trouble living? Can you afford childcare? Are you able to get new clothes for your family? They're very personal and intimate questions that do not translate to a call center. They don't translate to a 1-800 number somewhere else calling in, checking in on a patient. These types of interventions and conversations and interviews happen in a local community, in a local pharmacy, with the patients knowing the pharmacy technician. Can we go to the next slide? And this gets us into community health worker. A community health worker is not limited to pharmacy technicians. A community health worker can be in any aspect of the community, but pharmacy technicians can become community health workers, and that's the secret sauce. Community health workers are frontline public health workers who are trusted members of and/or have an unusually close understanding of the community served. This trusting relationship enables community health workers to serve as a liaison link intermediary between health and social services and the community to facilitate access to those services. They focus on knowledge, outreach, community education, informal counseling, social support, advocacy. So they are members of our community. They're that person you know that knows the answer to everything and can help us with anything. And they are just a wonderful resource. And so instead of just having a community health worker in a public health department, we're now starting to put community health workers in community pharmacies where patients are already coming more often than not to get the care that they are looking for. Can we go to the next slide? And so the requirements to be a community health worker is to have essentially just a high school diploma, and then some post-secondary education may or may not be required. It kind of is state dependent. So in the US, we have our 50 states. Each one kind of requires or regulates community health workers a little bit different. So I'm here in Alabama, and we actually have no regulation over community health workers. Whereas in another state like Missouri, where we'll talk about a pilot project in a little bit, there's a Missouri credentialing board, which is the authorizing entity or credentialing entity to say whether or not someone is a community health worker. What we have seen across all the states, though, is that for the most part, a lot of individuals will go through a community health worker class. So they'll go through some sort of training program. The one that we teach is 16 weeks long. It's 2 hours live every Tuesday night. So I'll be teaching it later tonight. And we find that that's a good way to cover a lot of material. We go through an entire textbook. So it is almost like a college level class to augment and give this kind of training. The training typically really covers a lot of the different skills on how to help patients' communities. For example, community health workers who work with Alzheimer's patients may learn how to communicate effectively with patients who have dementia or their caregivers. And oftentimes we see kind of standard qualities that we look for great community health workers, like analytical skills, communication skills, instructional skills, interpersonal skills, and problem-solving skills, aka all the great skills of a pharmacy technician. If we go to the next slide. And so what does a community health worker look like? Here are 9 community health workers in a pharmacy in Missouri. These are actually them. They let us take their photo and put them on these slides because we always talk about them because they're wonderful with all the work that they do. They help patients and their families navigate healthcare system, accessing local community services and non-local resources. And when I talk about these local community resources, what I'm really emphasizing here is it's dependent on the community. And so in this small town, Charleston, Missouri, one of the resources is you can actually call the police department and they have a connection with a local hotel and they can provide housing for patients in an acute distressed need. And so this is what we're talking about with the social determinants of health, finding those inroads within community pharmacy. You have a patient, you've identified that they're having housing insecurity. Instead of saying, bye, good luck, the community health worker says, I know the housing department. I can get you some free housing for the next 2 weeks. Let me connect you to them. And they connect the dots. And so the pharmacy is now addressing the social determinant of health barriers to the patient's health outcome, addressing health inequities, and really making sure that everyone has a healthier outcome. And it's really addressing all of the things that we talked about with the poor health outcomes in the U.S., the high cost, and we're addressing it from the local community. They facilitate local and accessible destinations for soft handouts for patients in transportation and or in need of services. We have one community health worker. They recognize that the patient's yard was not mowed, right? So the grass was overgrown. Because that grass was overgrown, the ambulance could not get to the house. Because the ambulance could not get to the house, the patient could not get picked up to go to dialysis. So we have a patient that wasn't getting dialysis, and it was attributed to the fact that the lawn wasn't cut. And the community health worker is the one that identified that difficulty, identified that barrier to care, got someone to come in, the local high school. They mowed the lawn. Because the lawn was mowed, the hospital was able to get there. They were able to pick up the patient was able to go to dialysis. So again, the things that we don't necessarily correlate with a pharmacy technician, where it's more mechanical, addressing the pharmaceutical optimization, but at the same time, by being cross-trained as a community health worker, they're able to address problems we identify in pharmacies. We can go to the next one. And so this is just kind of a framework of how you can start to advance social determinants of health clinical services in a community pharmacy. And I really think that this is a brand new service line within pharmacies. We think about medication services, we think about medications, we think about over-the-counter services, we might even say like clinical services. The other way to think about pharmaceutical care when you kind of look at like an accounting report is I really think that we need to have a line item that says health equity services. When we think about delivery services, many pharmacies are delivering medications to patients. Heck, some of our large national chains are using drones to deliver medications to patients' houses. That's addressing a social determinant of health. That's access to care that we're doing. And so that should be its own health equity kind of line item when we think about the role of the pharmacy in helping patients. With enhanced services, that can be medication therapy management, that can be medication deprescribing. With the social determinant of health identification and screening, this is when we start to roll in technicians and delivery drivers. But when we start to do the assessment, follow-up, and implementation of social determinants of health, that's when we need an SDOH specialist, and that is our community health worker. Then we go to the next slide. So what does this engagement really look like? Tell me, how did you like to get your medication information? Do you want a piece of paper? Do you want us to talk about it? Do you want a QR code and watch a YouTube link? Tell me about your situation right now. Are you struggling to get food? What's the drinking water in your house? Are you having difficulty getting to your job? What are you hoping for? What are your worries? What are your personal goals? All of these questions need to happen by a local person in a community, not someone in call centers or in a different city. It has to happen local. And so that's the benefit of having the community health worker cross-trained as a pharmacy technician, because you're creating a relationship and you're allowing patients to be open and honest, and they're going to have these things that they have to break down that are kind of scary or hard to sometimes talk about, but they're going to do it with that local connection. And so a lot of what the community health worker does is receiving referrals and connecting our patients to local services that meet our patients' individualized needs. be it housing, be it food insecurity, get them to the food bank, help them get toys for their kids, help them get clothes, whatever it might be. It could even be woodworking. We had one community health worker that found a high school, literally a high school, that sent out high school students in the US, and they would do woodworking. And so when they did a home visit for a patient, they realized that the railing was unsteady and it was an unsafe environment. And so they got the high school kids to come out and make new railing for the family's household. Like, again, not the things we think about within a pharmacy, but things that are addressing our health and affect the health of that person. Now they're not going to fall. Now they're not going to break a hip, all because we got some high school kids to do some woodworking. You can do the next slide. And so this is a pilot project. It's a little bit older, but I think it's really important to just highlight the role and the impact of community health workers in pharmacies. And so in this pharmacy, this is our friends over there in Missouri, they had a community health worker, they had a delivery driver, and they had a pharmacy. The community health worker was a pharmacy technician. And you can see that with the graph, we'll just focus on the graph because it's easier, it's pretty, and for me, it's 7 in the morning, so we gotta look at pictures because it's easier to look at. And you can see that most of the quick, instantaneous visits were from the delivery driver. There were over 1,200 visits by a delivery driver that lasted less than 5 minutes. So what was happening is our delivery drivers were going out, delivering medications or over-the-counter services to patients in the community, and they were identifying issues. And then that delivery driver would refer that patient within the pharmacy to the pharmacy technician / CHW. That CHW then would go back out to that patient's house and have an extended visit, anywhere from 5 to 30 minutes to sometimes even greater than 30 minutes, and did a longer interview or conversation with the patient to find out the barriers that were affecting their care. If we can go to the next slide. So in 6 months, there were over 1,400 delivery driver assessments, over 275 unique sites, and over 200 community health referrals. Medication optimization led to $70 per member per month out-of-pocket savings. And so what happened here is that the community health worker / pharmacy technician was interviewing the patient. They identified areas around medication optimization. They identified areas where there was a cost burden, and they would refer that patient to the pharmacist. They would just turn around and say, hey, pharmacist, this is the issue. Can we find an alternative? And that was saving patients $70 per patient per month. That is a huge amount of money in these super rural, underserved communities. There was over $87,000 saved in out-of-pocket pharmacy costs in 6 months within this one pharmacy. 10 patients were converted over to medication packaging. Patients were connected to transit services to make sure that they got to their doctor's appointment. We connected patients and caregivers to financial support entities, helped them get AC units or heating units for their homes. We engaged with local payers and providers, went to local health fairs, and engaged health departments and school districts. We can go to the next slide. And so really what we kind of want to differentiate here is the role of the pharmacy technician: prepare medications, perform calculation on medication preparation, interview patients to collect information, adjudicate third-party claims, and support compliance with regulatory needs. The community health worker is approaching health in a different way. They're approaching it from local care coordination, referrals to local resources, home assessments, social determinant of health risk assessments. And so when we combine the two and have a cross-trained pharmacy technician, community health worker, we have this expert in the community in our pharmacy that is able to help with medication delivery, medication optimization, but at the same time, help with that patient's optimization and really address health equity. Can we go to the next slide? And so our takeaway here is that the community health worker, pharmacy technician, is a problem solver. They're the person that goes the extra mile. That patient says, oh my gosh, I can't get that medication because it costs too much. The CHW has the training and the skill and the gumption, if you will, to take it a step further and help that patient find an alternative or get that medication at a lower cost. Thank you, and I look forward to Q&A at the end.
Thank you, Jake, for this very informative, well, actually food for thought talk on how close-knit community care can look like. And again, thank you for getting up so early in the morning. Okay, on to our next speaker. From Denmark, a little bit closer to at least my home. For a second talk, we have Anne-Marie Groenbach. I hope that's the Danish pronunciation of your name. And as a pharmaconomist, the Danish word for pharmacy technician, Anne-Marie is both working in practice and in governance. So an excellent position to have an overview of the roles and responsibilities of Danish pharmacy technicians. Anne-Marie, floor is yours.
Thank you. Thank you. Well, as said, my name is Anne-Marie Grønbæk. I know that isn't easy. I don't think it was supposed to be. I don't think it's made for global associations. And I am the president of the Association of Danish Pharmacists, and I have been since 2020, not 2000. I am a pharmaconomist. That's what we call technicians in Denmark. And I have been a pharmaconomist since 2007, and I've been working in community pharmacy ever since. And thank you very much for the opportunity to present the results of this study, Strengthening Medication in Danish Municipalities, a mapping of challenges. This study is carried out in great collaboration between the association I'm the head of and the Association of Danish Pharmacies and Pharmacon, which is the only Danish school of pharmaconomists. Next slide, please. Yes. We decided to do this study because we in Denmark see that 68% of the registered non-intentional accidents in the municipal institutions such as nursing homes and home care and residential facilities are due to medicine management. And the number has increased over the last years. And maybe it's because there are much more focus on reporting these unintentional flaws that is bigger now, but anyway, it is getting bigger every year. Until now, all studies have focused on which errors there are seen and not on what are the experience challenges and what are the problems with the medicine-related tasks in the municipalities. And that lead us to the purpose of the study. So the next slide, please. Yes. The purpose of the study is to map the challenges with medicine-related tasks in the municipalities identified both by municipal managers, but also by talking to the municipal employees. The purpose of the study was also to use the results in an investigation on how pharmacy technicians from the local pharmacies can contribute to strengthen the medication safety in the municipalities. Yes, next slide, please. Yes. This is how we conducted the survey to uncover the first purpose of mapping and understanding the experience with the medicine-related tasks. We made a semi-constructed individual interviews with 2 to 3 managers from 10 different municipalities in Denmark. The municipalities were selected on the basis of size, both big and small, city and country, and spread all over Denmark with 2 municipals in every 5 regions of Denmark. We covered 4 areas in the municipalities. Could you just press one more time? Yes, one more time. Yes, and that was elderly care, the social vulnerable and people with disabilities, children and young people, and disease prevention and health promotion. From the interview with the managers, 5 major categories were identified from the content of analysis, and they were further explored by visual storytelling and interviews with municipal employees. We chose visual storytelling to get closer look to the employees' everyday work with the medicine, and because visual storytelling somehow makes the invisible visible, and you can talk about why did you take this photo, and it makes the storytelling easier for the employees. Next, please. Yes. This photo is taken by a nurse who wants to illustrate how difficult it could be for home care nurse to go out to the patient and give medicine and do the dispensing and so on. And he can't follow the needed instructions because of, in this case, mess in the patient's home, It's floating around with medicine boxes and gloves and trash and everything is all over. Yes, thank you. There's just one way we did it. Yes. To uncover the second purpose, you can press one more time. Yes. The second purpose on how pharmacy technicians from community pharmacists can contribute to strengthen medical safety in the municipalities. The results were presented by a workshop with stakeholders from community pharmacies, the municipalities, the Danish Association of Pharmaconomists, and the Danish Association of Pharmacies. The participants discussed the results, pharmacy technicians' contributions to solutions, competencies, facilitators, and barriers to their contribution. Yes, next please. Yes. So these are the results. The result is of a content of analysis that covers both interviews with 27 managers and visual storytelling by 17 employees from 10 municipalities in Denmark. And they were residential workers, they were kindergarten teachers, nursery nurses, and nurses who are also leaders, social healthcare assistants, and social and healthcare helpers, and occupational therapists. And here are the identified categories describing challenges of specific medications tasks. And we'll go through the yellow ones because of the time limit and because we have so much data. Yes, please, the next one. Yes, one of them was medication during transitions. It was a very big challenge. As you see, one manager said that it's like that we still joke a little about it if a patient comes home after discharge from the hospital and everything is correct and just falls into place, then we celebrate with cake in the office. And it's not only the medicine, but most often it is the medicine that is the reason for errors. Managers in the elderly care area point out that there's a gap in the management during transitions between pharmacies, hospitals, municipalities, and general practice, and it requires leadership and communication if challenges of medicine in the transition are to be resolved. Especially the rehabilitation sites, medicine is a big issue and is time consuming. These patients are in a vulnerable situation as they are handed over between sectors at critical times in the process of their illness. And nurses spend a lot of time cleaning up in the medication at these sites. Then there's home care. Home care employers experience that they do not have time to check the medicine because they are busy and drive around to patient in the schedule, so they don't have the opportunity to be thorough, detail-oriented, or to detect if there are errors or changes in the patient's medicine in transition, for example, if it's discharged or it's been a visit to the GP. Sometimes nurses experience the patients are being prescribed unnecessary and inappropriate medication during transitions. They experience that patients get medicine they cannot tolerate or does not need anymore, for example, laxantia or painkillers. And in regard to this, the municipality also in general experience that the medicine changes during transition and it leads to errors in the medicine list because sometimes doctors are too busy and they are not always update the medication prescriptions. Yeah. Also, the managers in the elderly care zone have that not always able to get the medication when the patients are discharged, and that's especially in the rural areas. The pharmacies are not necessarily open 24 hours a day, and the hospital forgets to send medicine home with the patients, and the patients are and the relatives have this problem to secure the right medication. Managers and employers in the elderly care social area experience that it is difficult when there are several physicians in charge of the patient's medicines because which physician is responsible for the medication during the transition. Municipal employees have questions about what to do in relation to the medicine, but they do not know who to ask about what. And in relation to that, the municipalities also point out that the communication and the collaboration between the different parties is very important during these transitions, so the municipal employees know how to handle the medicine and who to ask what. Yes, and we have a picture more on the next slide. And they took this picture to illustrate that the patient keeps falling down between two chairs. And we have a saying in Denmark about this: when nobody is responsible, nobody is in charge, and nobody takes charge, because everybody says it's the other ones who are supposed to do it. Yeah, thank you. Next one. Yes, and then the right competence for the right task. We have a picture more from one of the employees. Yes, and this is to illustrate that there are a lot of hands and a lot of different competencies helping the patient. In the different educated employees need to work together and use the right competence to the right task. And sometimes it is a challenge, and it will result in errors. And that's what this is supposed to illustrate. We all participate in helping the patient. Thank you. Yes. I do worry about these interaction, about the fact that our employees do have the responsibility. This would be my primary concern about medicine. It is our social and health care workers, and of course also nurses, who in large extent have the responsibility. And this shows that they have the responsibility, but it does not have their whole focus. They have a lot of different tasks that they are supposed to take care of when dealing with the patient, and it's not easy to even keep up with everything on the patient, but also keeping everything knowledgeable up to date, and that is very even scary for some of them, because they know it's difficult. They do it anyway, but they don't feel confident in doing many of these things. Yes. The managers do feel that the social workers take this medication task seriously and gets all their full attention. But because they are not educated in any way about medicine, several municipalities are working to increase the medication competencies of exactly these employees. But despite the managers' experience, the employees still feel that they are on unknown territory. Yes. Yes, thank you. Yes, and then we will talk about the second purpose of the study, and that is how pharmaconomists from community pharmacies can help strengthen the medication safety in the municipalities. Yes, one more. We were at a workshop and we came down to these key points where we can help the municipalities strengthen their medication safety. And it's a lot of different targeted actions. And in Denmark, the community pharmacy doesn't have a big role in the healthcare system, not even in not even in Denmark. No, I'm not ready. Oh, sorry. Even Denmark, we don't have any, we're not usually a part of the healthcare system in the municipalities. There are pharmacy technicians and pharmacists at the hospitals, but that's actually the only place where we are a big part of it. More and more pharmaconomists are has jobs in the municipalities and working there, not in the community pharmacy. But we want to bring the community pharmacy and the municipalities even closer, and hopefully it will bring the medication safety even higher. As you see, there are several different ways of targeting this. There is a discharge service where we can help making sure that all the medicine is available for the patient, but also making sure that the prescription are renewed and the list of medication is just as it is supposed to be. We have also medicine handling services. So if anyone in the municipalities has any questions about medication, they can call the pharmacy. They can do that now, and some do, but it is even better if we can have some kind of collaboration where it's normal and they do it every time that they have doubts about something. Yes, there's one contact person. So it's the same one they talk to every time they call in, because it's sometimes they say they don't want to ask the stupid question. That doesn't matter. They can just call if they want to. We want to help with everything. Yes. And it was the 6 major categories that illustrate the medicine-related tasks that are experienced by municipal managers and the employees. Yes, and we hope soon we will be able to make some of these many ideas in real life, and we will test them in a new project, hopefully in the next year. So see if we can change anything and make everything better. Thank you.
Dear Anne-Marie, thank you for this, well, really practice-informed research project that you just presented it. I personally love the visuals. I'm gonna look into that research method. It looks great. Thank you so much. And then, ladies and gentlemen, for our last, but certainly not least, speaker of today, we have Trine Simonsen. Trine is also from Denmark. Trine is also a pharmaconomist, you know, pharmacy technician in Danish. But for a new context of today, Trine works in the hospital pharmacy. And she will take her with her on the journey of de-prescribing. Trine, the floor is yours.
Thank you so much. I look like a ghost too.
Perhaps it helps. I had that same a little while ago. Perhaps it helps if you stop the. Oh no, you're just do what you do. It's gonna be okay.
That's okay. Okay, thank you. So I've not done this before ever. So I want to apologize in advance if something is not clear, because I have never held a presentation in English like this before. So I apologize in advance.
It's going to be great, really. And we have plenty of time for all participants to ask you questions if they wonder about the stuff you told us. It's okay.
Okay. So I work on food. In my little country that you can see here, I work in the Department of Clinical Pharmacy in the hospital pharmacy in Odense University Hospital. Especially I work with distribution and safety and expedition of medicine prescriptions from the hospital. Among other things, I am part of a team that are responsible for the free medicine distribution to outpatients. And we also expedite medications to inpatients at the hospital and help out with other medication-related issues. So my work in the research unit is something I do on the side, purely out of interest. Yeah, next slide. Yeah, in the unit, we have these 3 focus areas, the sector transitions. It actually speaks a little into what Anne-Marie talked about, because we have this huge problem in Denmark. We have the de-prescribing and the clinical areas. And the one that I have been helping with in the units is, next slide, the de-prescribing one. Yeah, and we have multiple projects in the units, also with the portfolio from the de-prescribing. We try to cover both the healthcare professional part, the patient part, and we try to develop tools that can be used by the professionals to de-prescribe later on. I have been working on the patient part of the portfolio, and have been talking to multiple nursing home residents in my region. Next slide. Yes. I have written here that we have two projects. It's because the first one I worked on actually was we had an Australian questionnaire that we wanted to validate as a Danish one. So the first one where I went out to the nursing home residents were actually the translation, cross-cultural and adaptation and validation of the Australian questionnaire. It went rather problem-free, so we could use the questionnaire that we have developed to use in other cohorts. So we did, I'm sorry. Yeah, we used the questionnaire at the nursing home residents, and then we moved on to use the exact same in geriatric inpatients and geriatric outpatients. So we had actually a big amount of data that were poured into the attitudes towards deprescribing the perspective of geriatric patients and nursing home residents project. And I presented on FIP in Seville the results from the second project using only the nursing home residents population, because that was the population I have been working with. Next slide, yes. And as anybody knows by now, I think that the use of medications with questionable benefits is common in these patient groups. When a Danish person is brought to a nursing home resident, the life expectancy is 2 years or less. So it would be rather normal to look at the medication, see if anything is not important anymore. But several studies shows that when the nursing home residents get into the nursing home residence, either the medicine burden stays the same or it increases. Also due to when they are hospitalized, as Anne-Marie also talked about, they get something for pain and something PPIs, and they forget to take it away again when they are shipped home, and they just keep on taking it. And what we wanted to do was to explore the attitudes toward deprescribing amongst the residents on the nursing home, because if they didn't care, it was abundant to do anything about it. We did it in the way that I read the questionnaire out loud for the residents, because they are really bad. They can't hold a pen, and some of them can't read. So I put in front of them the response options and a huge font, like huge letters, so they could see what options they had to answer, and I read out loud the whole questionnaire. Yeah, next slide. And not surprisingly, many of them took a very large number of regular medicines. 49 was between 5 and 9, 72, 10 to 14, and 6.2 up to 15 and more. So this was not surprising, we knew that. But some of the results were like self-contradictory, and that was quite funny to see, because more than half of the residents believed they took a large number of medications, but 88% of them were satisfied. So that doesn't quite collide with each other. And we see the same with the 81 said that they would like to know as much as possible, but only 51 knew exactly what they were taking. That is very contradictory. It doesn't make sense. 35% would be willing to stop of their own. That's quite weird. Why would you do that? If you trust your physician, why do we want to try and stop? But up to 85 of them would be willing to stop if the physician said it was possible. And it was quite obvious that if we wanted to work with deprescribing, we had to get the physician involved. and quite surprisingly, only 31 would like the physician to reduce the dose. So it's all or nothing. They don't want to be reduced, but if the doctor says they can stop, that's fine. That's also kind of weird and quite surprising. So the conclusion was that the nursing home residents were open to deprescribing, but mostly so if the physician was the one to say it was an opportunity. And so we have already now, they've started a huge project where several private practitioners are helping talking to some of their elderly patients about deprescribing. So they have been developed some tools that they can use for the deprescribing conversations with their patients, and it will actually be extremely exciting project when it's done. It's probably far out, but it's on the works, and it's very interesting. And we have been using these projects to develop the tools that the physicians now are using. So yeah, thank you for having me.
Good job, Trine. Thank you so much. Thank you for this interesting talk. I think you painted a picture of a new starting project that can branch out in so many different branches. And it would be nice to have a closer look at the data, because yeah, sometimes it's even, I would say confusing, but let's keep it interesting. And thank you for, really taking the time to actually print out all your questionnaires on font size like this. Good job. Okay, that concludes the 3 talks of today. So for now, we will enter into the question session of this event. While I was really trying to get a grip on, next slide, please. So Marwan, if I could ask your assistance, please. Are there any interesting questions that need to be answered in the Q&A tool? And while you're sort of trying to gather them, first of all, question to Jake. If you think about what you just explained to us, what do you think will be a next step to implement this kind of close-knit healthcare all over the US, or even, neighboring states?
Yeah, so thank you for that question. We're already doing that. So the reason I'm super involved with community health workers is my day job is running an organization where we develop quality measures and we evaluate the quality and safety of community pharmacies. And one of our measures is advanced pharmacy technicians, because we make the claim that when a pharmacy has advanced trained technicians, then that pharmacy is better quality. And we believe that's true. And so the way that measure works is your denominator, your bottom number, are all pharmacy technicians in a pharmacy, and your numerator is if they have advanced training. Can they do immunizations? Can they do product verification? Mental health first aid? Can they be a community health worker? And so we want to support any technician to excel in any of those different areas. And so that's why we have this course. Right now we have learners from 6 different states that have been taking it, helping them, and a lot of it's grassroots. The other kind of initiative that we're working on is in the US, you have 80,000 pharmacies. You have the big box chains, the Walgreens, the CVS's, and that's about 8,000 to 9,000 pharmacies each. There's also 20,000 independent pharmacies, and those tend to be where the patients are. Those tend to be in the rural communities. And a lot of those independent pharmacies are aggregating around clinical services. And so we've launched a network of pharmacies that focus in on health equity. It's called CPESN Health Equity. And so we actually support any pharmacy in our network to be market ready to address health inequities. And one of our standards to be in our network is to have a community health worker on staff.
Thanks. Yeah. I didn't expect it to be oh, sorry, lights going off here. I didn't expect it to be easy, but I was a really well thought of answer. Thank you very much. Trine, I actually found the question box, and there was some attendee who was wondering if you had any problems with ethical approval for this research due to the nature of your participants. Was that something that you discussed with the research team? Did you have to fill in extra forms? What was that like?
Yeah, thank you for that question. We had to do a cognitive test before each with each patient. So we had a test that we did, and they have to score 8 or above to be. They had to be cognitive respondents, so they could sign a paper that it was okay to use their answers. And we also got a printout of their medications. Actually, I am not. I have not been a part of that part of the project. What they use is something about the ATC codes they have been using. So we got a signature from each patient, and if they couldn't sign, we were prohibited from bidding them to be a part of the project.
All right, great. Then also a question from the more educational part of this session, both for Anne-Marie and Trine. Can you, based on your research, can you think of practical implications that your data is providing for, say, pharmacy technician training? Is there anything that we should address in training based on your research?
We are currently making a new education for pharmacists. We are currently at a level 6, like a bachelor's degree, but we are getting a bachelor's degree in the near future, 2025. We hope the first one will start. And what we see is we need something more alongside nurses, being near the patient, talking to the patient, bedside manner, if you can call it that. We have pharmacy technicians in Denmark who are giving the patients the medicine, tablets, plasters, all of kinds of medication, and they are coming closer and closer to the patients in the nursing homes and on the hospitals. So we see clearly that the technicians in Denmark need some kind of not communication, but some kind of emotional help, like nurses, and so they can so they don't get affected by what they see and what they experience when they are near the patients like this. That is definitely something that we need in our current education. There's a lack of that, but we also see that we are very highly educated for technicians, but we need even more. We need even more because there can't be a pharmacist everywhere, so they use technicians, and the requirement for us are higher and higher every day. So we are taking it a step further.
Right. Thank you. Trine, would you have anything to add to that based on your data?
Well, the work that I do in the unit is actually, it's very, very, very high academic level in the research unit, and it will for sure be a good thing when we get the better education, because there will be more possibilities for pharmaconomists to pursue the research part of this world, because as the education is right now, it's really not an opportunity. Our education is very practical, so it's not for everyone. I will probably say that most pharmaconomists, as it is now, will not want to go into research as this one, but that will change with the new education. So that's it's for sure a step up for our education.
Maybe even start as an elective course. You could do that. Okay. All three speakers, thank you so much. Let me get back to the slides and see what we had in store for you further on. Yes, let me get this one. I was asked to ask for your attention for tomorrow, because tomorrow it's going to be just as good as a session as it was today. So if you're interested, just use the QR code, and if you want to join future FIP digital events, just look at the website. And yes, I think we had a great session, and the first session was great as well. I was very happy to see you. We're still with 179 participants. Woohoo! Good for us. We made it. I saw in the chat that we had participants from all over the world, so it was really nice to share International Pharmacy Technician Day with you all. I'm looking at Marwan. Did I forget anything? Do we need to inform our participants on other stuff, or would this really be goodbye and even see you tomorrow?
Thank you, Tamara. This was a wonderful day. We thank everyone, the chairs, you and Ryan, and all our speakers. We had a wonderful day. We wish that we will have as much as participants that we had today in tomorrow's meeting. So in tomorrow's symposium, we'll have also 2 sessions, and we'll be having the closing remarks. We will be having speakers representing other regions of the world. We had questions about other regions. So tomorrow we will have representation from other regions. We wish that you can make it and be with us tomorrow. For all of you that are interested in the FIP work, we encourage you to come back to us, and we want you with us in our Pharmacy Technicians Advisory Committee. We have a lot of projects, a lot of work to be done. Thank you, and see you tomorrow. Thank you, Tamara.
Bye-bye.